If you would tell her, we're going to be talking about PET scans today, and everyone wants to know about how to find out more about the inside of their body without cutting it open. So this is absolutely apropos for our population. Could you tell us what you do and where you do it?
Hi, Daryl. Thank you very much for the invitation. I'm honored to be in your company, and hello to your audience. I practice in nuclear medicine at Stanford, where we have a large group now of more than 60 practitioners and facilities throughout the Bay Area.
That's super. And today, Allen Edel from our patient community is going to be asking lots of questions that I believe most of our audience is going to be asking virtually in their heads, sitting virtually behind me. So Allen, if you would begin.
Sure. Actually, before I get into some of those questions, just this morning, I was reading your PYLARIFY training manual, and I was thinking that, PYLARIFY is, for our patients' benefit, is one of 2 PSMA PET scans that the FDA approved. The advantage of PYLARIFY, of course, is that it's based on fluorine-18 rather than gallium-68, and fluorine-18 is easier to transport, to get around, to use. So it's starting to, and with Medicare approval, it's starting to gain wide adoption. However, I worry about the lack of experience of radiologists out there. And when I was reading your training manual, I saw all the possible misinterpretations that are possible. I was wondering, can patients and their doctors request second opinions from you?
Alan, that's a very good observation about PYLARIFY. And it is not specific to this agent. Anything that's newly approved, there's a learning curve, right? We started using PSMA 11 in 2015, around the same time as colleagues at UCSF, UCLA, and others were using it in the United States. We switched to PYL in 2018 because at my institution, our ethics committee decided, and I think rightfully so, that patients should not pay for a research scan. So there are more than 450 patients who were scanned since then, did not have any out-of-pocket costs for these PSMA scans. Wow. So we have experience just like others do. Now that both are approved, and I would say that at this point only PYLARIFY is widely available throughout the US. The kit for PSMA 11 is still undergoing FDA review, so that will come as well. But as of now, PYL is the only one available countrywide in the United States. And there are many efforts by the company behind it, by the professional society, the Society of Nuclear Medicine and Molecular Imaging, by other professional groups to organize training for physicians. This is not the first time this is happening. We went through the same process with gallium dotatate in 2016, with Axumin for prostate cancer in 2016, and we had many, many physicians participating at the annual meetings in training courses. And you're absolutely right. When you go from a few centers of excellence providing this with large experience to community hospital and other places, we want to avoid misdiagnosis or having people chase things that are not real. So I'm giving a long answer to your question. There are many places that have opportunities for second opinion. My hope is that although that's feasible, in the short run, we will be able to train enough practitioners that this will not be an issue. And this training is at no charge to the physician. They can just go to the website of SNMI and participate in the training. It's at no additional cost to them. So there are many groups who are putting a lot of effort into making the knowledge widely available. We also host physicians who want to come and observe how we do this. So there are many avenues to improve, and everybody's fully on board and fully aware that this may become an issue. And I'm really confident that it will not become one.
Great. what I'd really love to hear about is your work in all kinds of molecular imaging. First of all, for patients, can you tell us what we mean by that term, molecular imaging?
Yes. So if you think of a general radiology exam, like a radiograph or a computed tomography scan, a CT scan, you have X-rays coming from outside of you and detectors on the other side. And so we take pictures of what your body stops or what it allows to pass through. So that's X-ray use. In nuclear medicine, we target a specific molecular process, hence the molecular in molecular imaging, and we attach a small amount of radioactivity, either fluorine-18, gallium-68, or either other isotopes. And these are injected. So the radiation comes from within the patient, not from outside. And we follow biological processes, molecular processes as they happen. And so that's the molecular imaging part of it. And these days, modern molecular imaging is coupled with anatomical imaging. So that's why we have PET, positron emission tomography, together with CT in PET-CT, or together with MRI in PET-MRI. Or on general nuclear medicine, we have SPECT, single photon emission computed tomography, coupled with CT. So these days, it's very rare in advanced centers to have just molecular imaging on its own. We get a lot of knowledge from the anatomical information from CT or MRI, and that helps us improve the accuracy of the diagnosis.
Now, with molecular imaging, particularly for PSMA, it involves a positron emitter attached to what's called a ligand that then attaches to the actual cancer cell. Can you explain what a ligand is?
Yeah, this is not my original explanation, but I like to use it. If you think of these receptors on cancer cells as door locks, the ligand is the key that goes into the door lock and opens it, right? Attached to this key, which can be a peptide, can be an antibody, it can be another small molecule, you have a chelator. So that's a linker between the key and the isotope, the radioactive material. And you can use the radioactive material for imaging, such as gallium-68, fluorine-18, copper-64. And if something lights up, if you find the key and you unlock it, if you find the lock and you unlock it with the key, then you can use the same compound, the same ligand, now with a more powerful form of radiation, such as lutetium-177, copper-67, actinium-225 for treatment. So that gets a little bit into what's now described as theranostics, the combination of therapy and diagnostics. But I think the easiest thing of thinking about it is this concept of having a lock, having a key, and then attaching to it one radiation for imaging. If you see something, you treat it with a different type of radiation.
Thank you. That makes it really clear. Now, getting into the kinds of molecules like PSMA that are expressed on prostate cancer cells, one of your to me, more fascinating explorations is into gastrin releasing peptide receptors. Can you tell us about that? Are they expressed on all prostate cancer cells?
Thank you for the kind words about that work. So gastrin-releasing peptide receptors, I'll refer to them as GRPR for ease of conversation here. They're overexpressed in several cancers, not just in prostate. And while data about PSMA suggests that about 90% or more of cancers will overexpress it to various degrees, data for GRPR indicates anywhere from 60 to 100%.
Wow.
There's some overlap with PSMA, but not perfect. GRPRs are also expressed in estrogen receptor positive breast cancer, in GI stromal tumors, in some lung cancers, in some GYN malignancies in women. So they're very attractive because they don't just attach to prostate, they attach to other cancers as well. And as I said, we were one of the early users of PSMA in the United States with help from our colleagues in Germany who developed the molecule. But it's difficult to think that, a disease that on average is 10 years in its course, prostate cancer, will have the same expression of the same molecule from, biopsy when you don't know about the diagnosis all the way to advanced stages. So in my mind, no matter how good PSMA is, it's good to have options when PSMA is no longer expressed. Or even when both are expressed, maybe you want to alternate between them so that you minimize the adverse events from one or the other. All of these are drugs, so they come with certain side effects that we need to be fully aware of. So again, using an analogy, it's risk and benefit, right? We can get hit if we cross the street, but we look left, we look right. When it's clear to cross, we cross. I think the same way as is with diagnosis as well as with therapy. If you need a radiation, then the benefits from it far outweigh the risks that are theoretical.
I know Michael Hoffman in Australia advocates getting an FDG scan along with PSMA. Is a GRPR kind of scan an alternative to an FDG?
You know the field very well, I have to say. I'm a big fan of what Michael has done in the therapy trial. And I think that we need to be careful how we use these treatments, including PSMA. There are patients who will not benefit, right? And you should know ahead of it because of cost and side effects. FDG is ubiquitous, right? You can get it anywhere and it's relatively cheap. So I think that doing FDG prior to deciding on a PSMA treatment makes a lot of sense. As far as GRPR, first of all, they're all just research right now. There's several molecules in research and development with different companies or groups. And we're learning. So at this point, although we have the largest population of patients who had both PSMA and GRPR scans, I can't really tell you what patients should get it and what not. We're still learning that. I can also tell you that some patients are negative on both, despite PSA that's rising. So again, biology is very complex, and as some more senior colleagues of mine used to say, biology has a way of messing things up for you. When you think you've got it, you have to go back to square one, and that's why it's called research, right? That's also a quote from a dear colleague and friend. So I would not be able to make a recommendation at this point, but there's a lot of people who are working on this. So stay tuned, more to come.
Well, one of the older kinds of PET scans, sodium fluoride PET scans, which is only good for bones. I just saw an analysis from NIH that said that it's much more sensitive to bone mets than PSMA PET scans. However, Medicare, I think, no longer offers sodium fluoride PET scans.
Again, I'm very impressed by your knowledge of the field, and I have to say that it's very unfortunate that CMS has a non-coverage decision. They recently reversed their non-coverage decision for non-oncologic indications, which was a victory for patient advocates, for patients themselves and the professional societies, but they did not retroactively remove this non-coverage decision for sodium fluoride and for amyloid imaging. And what's unfortunate, for sodium fluoride, CMS itself paid a very large registry. Tens of thousands of patients had sodium fluoride PET as part of this National Oncologic PET Registry, NOPR. Many centers throughout the US, hundreds of centers, provided information, not just the scan, but a questionnaire from the treating physicians before and after the scan. And it showed that vast majority of patients had changes in management based on the results of the scan. yet CMS moved the goalpost. And although this was done at their request, they came back with a different request when the results were ready. So it is a very frustrating development, one that I hope it will be reversed. I think the jury is still out there in the PSMA versus bone scan for bone metastases. In our experience, there are some patients with more lesions seen on a bone scan and on PSMA. However, I'm not sure that changes how you would manage those patients. So it may be that actually PSMA will be the one-stop shop, right? Because again, study from Michael Hoffman and his group show that at least in the Australian healthcare system, it is more cost-effective to do a PSMA PET-CT than to do bone scan and CT scans. Not sure how that translates into the American healthcare system. I guess someone will do that study. But the jury is still out, in my opinion, about whether bone scan will be replaced by PSMA.
Yeah, I know there's a lot of issues with just moving to PSMA when all the clinical trials in the last 20 years are based on bone scans. So it's the question that you have been instrumental in asking is, can it replace a bone scan? And as you say, the jury's still out. Maybe all those clinical trials will have to be redone with PSMA or with your new GRPR scans. I don't know how it's going to play out.
Yeah, and I think that, realistically speaking, money is a limiting factor, right? And we need to be cost conscious about what makes sense at a certain stage in prostate cancer and other diseases, right? So sure, you can have access to a lot of things, but does it make sense to have all that expenditure for the healthcare system without knowing what is the best time to do it? I think that, we need to go from, this or that finds a lot of lesions to, but which one makes an impact in overall survival and quality of life? So I think that that's the next frontier for the field, right? Where do you use it in a meaningful way for patients?
Right. Getting back to GRPR, one question I have is sometimes I've seen the ligand called bombesin and sometimes RM2. Are they the same thing?
Bombesin is a generic class of receptors that are part of this class of GRPR. RM2, it's one of the molecules, one of the keys that finds this lock, GRPR. RM2 has been used for a number of years. Another one is called NeoB. It's also in the same class of antagonist. There are others in development. So the good thing is that the field is now exciting not just to academia, but also to the industry. And there are many companies that are taking advantage of this, no pun intended, but scintillating environment for us. And so there's a lot of investment. And when there's a lot of investment, there will be good results coming out.
Cool. A lot of patients are recurrent and have very low PSA levels. And with PYLARIFY, it can detect cancer at very low PSAs. Is that also possible with RM2 or a combination of RM2 with PYLARIFY?
These require a little bit of a detailed answer. First of all, I would say at low PSA values, it's very important not just the right radiopharmaceutical, not just the right drug, but also modern equipment. By that, I mean scanners that are transitioned from standard to digital technology because they're able to identify smaller lesions. And I'll illustrate this, the Condor trial, the phase 3 trial that led to Pylarify approval, has a positivity rate of about 40% at PSA under 0.5. We had a research access program with Pylarify in 240 patients scanned at biochemical recurrence. In this cohort, all of the patients were scanned on a digital scanner. Our positivity rate was greater than 50% at the same PSA. It's not that the molecule was different. It's just that at our center, all the scans were digital, while in the trial, there was institutions that had older machines. And I think that for small lesions, having access to a modern machine is very important. In the cohort of patients for research at my institution had both Pylarify as well as RM2. The positivity rate at the same under 0.5, it's about 40% for RM2. And not all have the same lesions, and not all patients positive on one are positive on the other. So I think that in an ideal world, if someone is diagnosed with prostate cancer, they should have both scans. And if both show the same lesions, you go ahead and use whatever it's easily accessible or less expensive. If one is better than the other, you use that one. And if it becomes negative again in the future, you have options to switch to another target. So we everybody speaks about personalized medicine and care at the N of one. I think that this concept is illustrated here when you have access to more than one biological target.
You mentioned theranostics earlier. Are there therapies that can be done with RM2? Can lutetium or copper or actinium be attached to it?
Yes, in fact, both beta and alpha emitters can be attached to these type of molecules. There are small studies done in Germany and Chile with lutetium-177 RM2, but there's also a public phase 1/2 study by Novartis where they use their own version of the molecule, NeoB, that is looking not just at prostate, but other cancers as well. And there's several centers in the United States and Europe that are part of this phase 1/2 study.
So for therapy, does a problem with PSMA is salivary glands and tear ducts and kidney attachment of it. Does RM2 also have similar kinds of constraints?
The entire class has very similar properties. So there's no uptake in lacrimal or salivary glands, and there's no renal binding. There's renal excretion, but there's no, this class doesn't stay in the kidneys. There is uptake in the pancreas, but the pancreas is very radio resistant, and the dosimetry data shows that it washes out, this class of agents washes out from the pancreas over time while it stays in the cancer lesion. So the pancreas is not an area of concern. But while for PSMA, we have data from tens of thousands of patients who have been treated with good results, the work in GRPR is very early, very preliminary. So I don't think that we can compare this point outcome from treatment with one versus the other. As I said, it's good to have access to a new class of agents, and let's hope they work. But the work is very, very early. It will take a couple of years for us to get a sense of where will this class of agents work and also where it will not work.
Great. You mentioned molecular digital scanning, and I think I was just reading about Siemens has a new CT scanner that gets down to the molecular level. And of course, Stanford has one of the few PET MRI scanners in the world. Can you describe for patients what is the advantage of that over a typical PET-CT scanner?
Yes, you're right. We installed in 2013 the first of its kind from GE Healthcare PET MRI scanner. Siemens had a different type of PET MRI scanner since 2011. You need to understand that in order to have a PET inside a magnet, you need to make some profound changes to the PET technology. The magnetic field doesn't like to have PET electronics, and the PET electronics don't like to be in a magnetic field. So these vendors, they took different solutions, but they had to manufacture PET detectors that can live inside a magnet. So GE chose to go from photomultiplier tubes that look like miniature tubes from TVs from the 50s and the 60s to silicon photomultipliers. So these are slimmer, they're not impacted by the magnetic field, and they have very high sensitivity. And so those were built in a PET MR. The same detectors now are available in digital PET-CT scanners. So both digital PET MR and digital PET-CT, the PET detectors is superb. It works very well and much better than standard PET technology. The advantage of PET MR is, there are many advantages, but the one that pertain to your patient group is if someone needs an MRI and they need a PET-CT, the information in the prostate area and the pelvis from the MR, it's so exquisite that CT doesn't add much. So instead of one patient, instead of multiple patient visits, one for MR, one for PET-CT, if you have PET MR, one visit will suffice. And that's particularly important to guide biopsy in men who are suspected for prostate cancer, to guide local treatment like HIFU or brachytherapy, or to stage prior to surgery. At more advanced stage of disease and biochemical recurrence, at that point, PET-CT is as good because you need a fast throughput. You know, with digital PET-CT, you can get an exam done in under 10 minutes. Given the duration of MRI, a PET MRI, it's 30, 45, maybe up to 1 hour. So again, we have access to new technology. We need to learn how to use it judiciously. And in the course, in early stages of prostate cancer, PET MR makes a lot of sense. Later stages, PET-CT also make a lot of sense. And if you have access to digital PET is the way to go.
Wow. So a lot of patients make the mistake of thinking that, well, these PSMA scans are so good, it's telling us about every single metastasis in my body. And I keep telling them, no, once you get under 5 millimeters, they're really not that good. Are these new digital PET-CTs and PET MRs better than 5 millimeters?
First of all, I think that for many patients, PSMA is able to find almost the entire extent of disease. It is a very good molecule. So, but you're right. Once you get to a certain size, the spatial resolution of the machines gets blurry. So the signal kind of washes out in the background for small lesions. What we see is a combination of the physical resolution, which is determined by the machine, but also the concentration of the agent. So what I'm trying to say is you can have a 2 millimeter lesion with very concentrated signal that will light up and will light up easier or better on a digital scan. And you can have a 1 centimeter lesion with very little concentration that will not have signal on this. So I think that, again, it's biology, so we're learning. Definitely for low PSA values, having the scan done on a digital scanner makes a big impact.
Great. Now, I've been reading about all kinds of different molecular imaging, like HK2, UPAR, VPAC. Are you involved in any of those?
We have a preclinical program looking at MuPAR, actually, and researchers in Denmark, in Copenhagen, have the largest experience with that. We did not translate it into humans yet. It's still in the preclinical phase. There are other targets as well that are under development, such as markers of apoptosis, of cell death. So, for example, if you have a drug and you want to see if it works, you can use one of these looking at cell death, and there should be no signal prior to treatment. And once the treatment is given, if it works and cells are dying, then you should have the more signal, the more cells are dying. So they're all sort of interesting concepts that people are working on, but not at this point in the clinic yet.
So in terms of your clinical trials, can you tell patients what you are running so that they may be interested in signing up for them and how they can get involved in it?
Sure, with great pleasure. We have studies looking at PSMA and bombacin all the way from biopsy guidance to guiding local treatment, as I said, HIFU HDR prior to surgery, at biochemical recurrence. And one of the centers in partnership with industry trials looking at therapy, both with lutetium and hopefully in the future with alpha emitters as well. They are posted on the website, cancer.stanford.edu. It's our Stanford Cancer Institute. It lists all the trials that are available. It also, you can find the team members. We don't work in a vacuum, and I'm always recognizing that the best centers for this are centers where people in medical oncology, radiation oncology, urology, radiology, nuclear medicine work together. And I'm very proud that our working relationship is excellent with all these groups. And we have tumor boards where difficult cases are presented, and we have regular meetings with our colleagues. So that's another piece of unasked for advice, that if you want to have good care, go to centers where you have multidisciplinary teams. No one can function well in a vacuum. You need to have access to the expertise of people from multiple teams who are used to working well with each other.
Cool. Yeah, I wish you all the success in the world in recruiting for these clinical trials, because it's so important and game-changing for patient care. Thank you so much for all the work you're doing on this. Is there anything else you want to add on the subject?
Allen, I just want to thank you and your group for inviting me. Thank you for putting together the conference. And most importantly, thank you to all the patients, because they spend time to participate in these trials, and it's time taken away from being spent with the dear ones at a time when a lot of new information is thrown at them and they have to make decisions, and every minute spent doing something else, it's time that's not spent with family. So we all appreciate your participation in studies.
Thank you. That's Daryl. That's all I have.
No, Dr. Iagaru, thank you very much for this extraordinary and comprehensive presentation, a conversation about a difficult to understand subject. I hope everyone listening, even if some of these terms and sentences and such just sort of glossed over you, you should know that you now know more than 99% of all prostate cancer patients on the planet around PSMA PET scanning, and you should feel confident going into your doctor with any question you want about it. So thank you again, Dr. Iagaru. And I hope next time I'll pronounce your name much clearer and better. And thank you very much also for your research and the care that you give to your patients. I mean, we don't say that enough to doctors. You could have been an investment banker, but you chose medicine, and we're very grateful for that. Okay. Thank you. Bye.
Thank you.
Bye-bye.